Reproductive pathology, uterine conditions. So the uterine conditions are relatively higher yield, okay? Now, there's two types. You have non-neoplastic, so non-cancerous, and then you have neoplastic, which is cancerous. So for uterine conditions, non-neoplastic, non-cancerous, the first one we're going to talk about is adenomyosis. Adenomyosis, I'm going to give it to you short, is diffusely enlarged, soft, boggy uterus on exam, okay? Very important. Uniformly or diffusely enlarged that is soft and boggy, okay? You have to know that. That is how they're going to describe an adenomyosis. If you see a uniformly, and uniformly I'm saying it very importantly because there's going to be another pathology that I'm going to differentiate it with. Adenomyosis is uniformly enlarged uterus with soft and that is also soft and boggy, okay? Now, what does it mean? It means that there's a presence of endometrial tissue within the myometrium, okay? It's not present anywhere else, but it's present within the myometrium as well, okay? So keep that in mind. Patient can present with like pain after tubal ligation with uniform enlargement. They will always say uniform enlargement. Uniform enlargement with soft, boggy uterus, right? They love that. They can have heavy or painful menses with uniformly enlarged uterus, right? They can have dysmenorrhea with uniformly enlarged uterus, right? So you have to understand adenomyosis is uniformly or diffusely enlarged uterus that is boggy on uterine exam, all right? And it's due to the fact that there's presence of endometrial tissue in the myometrium only, all right? Next is endometriosis. Endometriosis is the presence of endometrial tissue outside of the uterus, okay? And they usually like to ask you what are like some ideas as to what causes endometriosis, because we don't fully know, but they like you to know there's some theories out there. One of the theories is the retrograde menses theory, and that means that they think that menses that goes retrograde up into the fallopian tubes and hits the ovaries can cause endometriosis because the main area for endometriosis to occur is at the ovaries. So it may be due to ectopic implantation of the endometrial tissue, secondary to retrograde menses at the ovary, okay? So that's one of the causes. That's one of the theories that they think is causing endometriosis, okay? What you're going to be seeing is nodularity and pain in the posterior cul-de-sac. If the patient presents with like severe dysmenorrhea and like huge amounts of pain with infertility, okay, and the pain's going to be diffuse, it's not going to be one-sided, you know that you're potentially dealing with endometriosis. Okay, so think about dysmenorrhea. They're having trouble with like their menses. They also have pain with their menses, and they have infertility, and then they have nodularity and pain in the posterior cul-de-sac. They can show you these images, these gross images of like the posterior cul-de-sac below the uterus. The posterior cul-de-sac is just like the area below the uterus. Like if you move the uterus anteriorly, what you're looking is underneath, and then you could see endometrial tissue there, okay? And what they say is that it looks like blood-filled chocolate cysts. Okay, and that's endometriomas when it's seen on ovaries. Okay, you have to know that chocolate cyst. Okay, that's from endometriosis. Next is endometrial hyperplasia. Endometrial hyperplasia can be due to essentially anything that causes abnormal endometrial gland proliferation. It's usually due to excess estrogen, unopposed by progesterone, right? Because what do we say? Estrogen is a crazy one, so estrogen is going to cause endometrial hyperplasia when progesterone is not available. So what could it be possibly associated with? We already discussed one. It can be associated with obesity. Because obesity, once again, has aromatase, so it can produce estrogen on its own without progesterone protecting it. And so that can lead to endometrial hyperplasia. Patients that have obesity can have an increased risk of endometrial hyperplasia. Another one, anovulation, which is PCOS, right? Because we're never ovulating, so we have constant levels of estrogen, but we never have progesterone. Lastly, one that's very important that they love to ask about is tamoxifen usage. Tamoxifen usage is a common cause, right? Because it's an agonist at the endometrium. Even though it's an antagonist, estrogen antagonist at the breast, and that's why we use it for breast cancer, but it's an antagonist at the breast, but an agonist at the endometrium, causing endometrial hyperplasia. All right? So if a patient has a history of breast cancer treatment and they come in with endometrial bleeding, you know that they could potentially be taking tamoxifen and they could have endometrial polyps. It's associated with endometrial polyps. All right? So keep an eye out for that as a cause of endometrial hyperplasia, tamoxifen. Now, endometrial hyperplasia leads to an increased risk of endometrial carcinoma, right? If you have constant production of cells, it can lead to a carcinoma. So you got to keep that in mind. We're going to talk about that in a second. So we're going to move on to our neoplastic cancerous uterine conditions. The first one is so high yield. It's known as leiomyoma, or also known as fibroids. These are benign tumors of the myometrium, okay? They're known as fibroids or leiomyomas, and it's the most common gynecological tumor throughout the whole entire world, okay? You have to know it. It's benign, but you have to know it, all right? So it's going to be seen in reproductive age females. And what they're going to say is that there's an irregularly enlarged uterus. All right. So why do you think I said irregularly? Because I'm trying to make a contrast in comparison to adenomyosis. Adenomyosis is uniformly enlarged uterus. Leiomyoma is irregularly enlarged uterus. So you're only going to feel enlargement in the location where the leiomyoma is. It's not going to be uniformly enlarged uterus. Okay. You can also present with bulk symptoms because that leiomyoma could compress on the rectum, or can compress on the bladder, or can go and compress on some abdominal tissue. Okay. So keep that in mind, right? It can cause constipation or a decrease in bladder production, right? Very important. And all that this is that it's a monoclonal proliferation of myocytes, muscle cells, and fibroblasts. Okay. It is estrogen sensitive. So you're going to see patients that have increased pain during times of ovulation because there's increased levels of estrogen throughout the body. Okay. And it will become larger with estrogen. All right, so you can see bulk symptoms only during their menses. Okay, so they're like, doc, every 4 months, or every month, every 4 weeks, I should say, I have like constipation, I have severe pain, but then it goes away after my menses, right? So, I mean, that could be endometriosis, or it could be leiomyoma fibroids, all right? So think about the estrogen-sensitive aspect because it increases the tumor size, all right? Now, what happens at menopause with leiomyomas or fibroids? It's going to decrease because at menopause, you have decrease in production of estrogen, so you're done. Leiomyoma and fibroids, very important. Remember, keep that in mind. Lastly is the endometrial carcinoma, okay? Once again, the common cause of endometrial hyperplasia or cancer is obesity. And if that's unchecked, the endometrial hyperplasia, secondary usually to obesity, but could be tamoxifen usage or other things like PCOS, it can lead to endometrial carcinoma, all right? So keep that in mind. It's usually in patients that are postmenopausal females, and they'll get abnormal uterine bleeding after menopause. So it's very odd to be bleeding after menopause. And when they do, you know that the patient could have potential endometrial carcinoma. Usually secondary to obesity. They like to talk about that. All right. Overall, that's it for uterine conditions, and we'll talk about breast pathology next.